It's important to realise that one of the major needs for patients with diseases such as rheumatoid arthritis is early diagnosis and treatment. There are national standards now in place from a body called NICE, National Institute for Health and Clinical Excellence, which recommends that all patients with rheumatoid arthritis should be started on drugs that modify the disease, called disease-modifying drugs, within 3 months of symptom onset. We know that such treatment helps to control the disease and to reduce disability. We also know that there is currently large variation in practice throughout the UK, and overall only around 10% of individuals are treated within that target time. We've also had a huge advance in knowledge of rheumatic diseases, and this has been translated in the last few years into new and powerful drugs. We therefore have the opportunity for driving forward change by instituting these treatments early. We feel that this national audit of early inflammatory and rheumatoid arthritis will drive quality change by providing data on individuals and how they receive such treatment, which should advise commissioners and other policy makers to institute most appropriate treatment for these individuals. A lot of the work that we've done today discussed the importance of linking together data from a variety of sources. For example, the British Society for Rheumatology has a very successful biologic register which has recorded data on patients, over 25,000 patients, on these new treatments. This has enabled detailed assessments to be made about the safety of these drugs, about comparison between these drugs. But this database could be extended to encompass other uses such as involvement of patients, commissioners, used more extensively in research and to influence policymakers. And it's also possible in the longer term to have a vision of linking data collection together so that data collected once by the clinicians and by patients themselves can be used for a variety of purposes, not just to influence individual patient decision making by patients and their clinicians, but also to provide quality data for audit, for commissioners, and ultimately to also influence the research agenda. What we've learned today is that there are such models, for example in Sweden, where collecting such data has been shown to be valuable in predicting responses of individual patients. And we would aspire to develop our data collections so that we can use these in a much more intelligent way, not just for improving the care of our patients now, but for enabling research to tell us exactly which treatment will help which patients at which time. I think the key is to link data sets together. We've learnt a lot today about how this has been done in other countries, and we've also learnt a lot about how health data has been collected and used for modelling in a more administrative way without a lot of clinical data. And there seems to be no doubt that if you can include the clinical data with this, that one should be able to predict better the health needs of individuals, and that the IT systems should be developed in a way that enables us to do that.